Thank you very much. So we're going to review, before we start looking at the various ways of implanting devices, we're going to review the anatomy of the appendage in full. I'm going to start off by showing you the anatomy of the appendage in the context of the body and surrounding structures. I'm going to show you my approach, a simple approach really, for analysing the left atrial appendage, component parts. And as we go through, we'll look at some of the landmarks that are used for occlusion of the left atrial appendage. So if we think about the appendages in terms of the rest of the 5 components of the atriums, in fact, all of the components of the atriums are relevant to left atrial appendage occlusion. So we're going to be talking about the left atrial appendage, which is usually the smaller of the two. The right atrial appendage occupies a much larger proportion of the right atrium itself. The veins are important, of course, venous access to the right atrium. The pulmonary veins, of course, can vary in their position with respect to the left atrial appendage. We're going to look at that as we go through. The septal component of the atriums is crucial for access to the left atrium, and we'll look at that. You'll be passing through the body of the left atrium. The appendage effectively sits on a oval-shaped body, and that can vary. And then finally, the vestibule of the mitral valve is also important to consider. Again, the position of the appendage relative to that structure. So all of these are important when we are thinking about occluding the left atrial appendage. In terms of the surrounding structures, the immediate surrounding structures, probably the most important is the phrenic nerve, the left phrenic nerve, and that will run directly over the tip of the appendage. It depends, of course, on the shape of the appendage itself. But I don't think that's been an issue in any of the occlusions so far. Here is the appendage in situ, and you can see that it sits obliquely between the left ventricle and the pulmonary trunk. You see the pulmonary trunk running immediately above it. And probably the most important space with respect to occlusion is this space here called the transverse sinus. This is the left side of the transverse sinus. It's a pericardial space, bleeding into this space obviously can create tamponade. Now, if we look at the tip of the appendage, you can see that it's lying over the top of the left anterior descending coronary artery, and then you can see lobes of the left atrial appendage coming down in a different direction to the main course along the obtuse margin of the left ventricle. And then if we look at the appendage from the side there, you can see the course of those lobes. And then if we follow the appendage towards the left-hand side, you'll appreciate the left pulmonary veins here. Here's the left upper and the left lower pulmonary vein, and the groove that exists in between the two, which will be the left pulmonary ridge, and normally contains within it the vein of Marshall, so the remnant, if you like, of the left SVC. So it is a fold, but it's also a muscular structure, and we'll look at that in more detail in just a moment. And then here is the oblique sinus behind the left atrium between the left and the right pulmonary veins. So just to give you an idea of the external anatomy of the appendage itself. And then, of course, perhaps the most important thing internally is the relationship of the atrial septum to the appendage. And here I'm transilluminating the true atrial septum. So this is the thin membranous portion, and this is the region that I would advise crossing during a transeptal puncture. Here is the appendage itself, the os of the oval of the left atrial appendage, with the pulmonary veins above and the left lateral ridge in between. So you can see that they're pretty well aligned in most instances. And ideally, as I say, we would want to cross the true atrial septum in this region, so transluminated portion posteriorly, inferiorly, and avoid the region of overlap superiorly. This will lead outside of the heart, and really avoid the region inferiorly, which could also potentially lead to complications. So most of the time, I think the appendage is aligned, sits sort of in the mid portion of the body of the left atrium and will be in correct alignment. Here's an example. So we've perforated the atrial septum here inferiorly, and we're putting our sheath towards the left atrial appendage. It's going through the body of the left atrium, and then positioning a little bit more. And usually there needs to be a little bit of a tweaking of the sheath, turning, anti-clockwise turning, to get directly into the os of the left atrial appendage. So that's the relationship of the atrial septum to the appendage. Let's look at how we should analyze the appendage itself. So in this heart, I've taken off the atrial chambers, the top of the atrial chambers. We're looking down onto the left atrium. And you can see here, coming from the aorta, the left coronary artery, dividing off into the LAD and the circumflex, which is running immediately beneath the narrowest part of the left atrial appendage. So, if you like, this is the part we're going to call the neck of the appendage. So that should be our dividing line. And then to the left-hand side, we have the lobar region of the appendage, which is the most complicated and most variable part of the appendage. And then on the other side, at the junction with the body of the left atrium, we have what we term the os. And then in between the os and the circumflex, we have this region which we variably describe as the neck, and often that's a smooth structure, slightly thicker, smoother structure, although that can change. And our landing zone for a device may not be at the neck, may not be at the narrowest region. It may be just distal, or maybe within the lobar region, or maybe within the neck itself. So the neck itself can vary in its length. This is a fairly long distance between the os and the narrowest tubular region. One thing that's been mentioned in a couple of studies is the limbus of the left atrial appendage. I think it may be useful in some circumstances. So what this publication describes really is the space that exists between the left lateral ridge and the vestibule of the mitral valve. So if you like, it's the inferior extension from the os of the appendage. And it can vary in its length and its morphology, and that may well be relevant to seating of the discs of device in certain circumstances. I think probably the most important part of this is the structure of the limbus itself, whether there's a pectinated region of the limbus or not. For the lobar region, let's move to the questions. So let's get you to get your voting pads, and if we can have the first question before I show you the anatomy. So first question is, what are the most common number of lobes found in the left atrial appendage? 1, 2, 3, or 4, A, B, C, or D. So if you vote, this one should be fairly straightforward, I guess, for most of you implanting, and yes, most of the time, as you'll see, it's 2 lobes. Second question. Just pause my video. What is the tissue like between the pectinate muscles and the left atrial appendage? Is it thick and fibrous tissue, A? B, is it muscular tissue? Or C, is it connective tissue only? Or D, is it best described as being paper thin? So if you'd like to vote on those options. and most describe it as paper-thin tissue. And in fact, if we just switch back to my slides, you are correct. It's in a normal situation, the tissue between the pectinate muscles, as you see here, we're looking down through the os of a transilluminated appendage, is paper-thin. There is some muscle fiber there very often, but it's very thin and fragile. And if you look at histologically, in the main, then you can see pectinate muscles are muscular structures, and then on the outside here of this histologic section, you can actually see the fatty tissue within the epicardial region. Now, in atrial fibrillation, that can change, so there can be fibrosis at the neck. It extends less into the body of the appendage towards the tip of the appendage. So in fact, the wall may be slightly thicker, and that may be an advantage for occlusion of devices. In terms of lobes, probably the best study is this one published some time ago. And as you said, most of the time it's 2 lobes, otherwise 3 lobes. And if you combine those two, then about 75% of cases will have either 2 or 3 lobes. So this is a nice example, I think you'll all agree, of a single lobe of the atrial appendage. You can see the narrow neck there, and just a single uncomplicated appendage really to occlude. But of course, there are lots of variations that have been described, and we've already heard of the 4 classifications: the chicken wing, the cactus, the windsock, and the cauliflower, which may be useful for analyzing, but there are a multitude of other shapes which are recognized and have been described. And I'm just illustrating some of them to you here. Here's an example of some slightly odd-looking appendages. So here you can see one which is hooking back on itself within the transverse sinus. And the second one here is a rather long appendage, which is running really right in front of the pulmonary trunk. So certainly there's lots of variations on that theme. Here's another sort of question for you. How would you categorize these particular endocasts of appendages? We're not going to go to the voting for this one. Perhaps the top left you might describe as a cactus. It's got a main sort of region with sort of branches quite low on. You've got the chicken wing here, which has a major bend in the appendage. This one, I guess you'd describe as more of a windsock. It's quite a simple appendage, and this one much more complicated branching pattern. Now, in fact, these are all the same appendage. This is the same endocast, which we've taken different images of, different views of. So certainly getting a good three-dimensional idea and image of your appendage is crucial. And studies have shown that the reproducibility in terms of shape is pretty poor. Describing in terms of the 4 different types is pretty poor. So how else could we analyze the left atrial appendage? It's clearly a complex branching structure, and we could potentially use mathematical analysis. We could use fractal analysis, as has been used for the trabeculations in the left ventricle, perhaps, to give us a number of complexity, if you like, describing the complexity of the left atrial appendage, and that's something that we're working on currently. So then moving to the neck or the isthmus, if I can have the next question, please. Which are the vessels that run directly beneath the neck of the left atrial appendage? Is it the left anterior descending coronary artery and middle cardiac vein, number A? Is it the circumflex and the great cardiac vein, B? C, the posterior descending coronary artery and coronary sinus, or D, the right coronary artery and small cardiac vein? So if you'd like to vote on that, please. So part of the answer, I guess, that we've had already. and circumflex and great cardiac vein. Yep. So we're almost unanimous in that voting. And here's an example. If we just switch back to the slides, please. Here's an example then of a nice chicken wing appendage. Certainly got lots of bends within this appendage. And you can see how the neck aligns very nicely with quite a large circumflex artery. This is a left dominant pattern here. So that relationship holds true pretty well, although of course the appendage can vary in its height on the body of the left atrial appendage. But the neck and the circumflex coronary artery certainly follow each other. Here's another example, multi-lobed appendage, and we've sectioned this just at the atrioventricular junction. So if we look at that junction from underneath, what you can see is that there are actually two vessels. One is the circumflex, which is actually stained in a yellow color, and the other, which has much of a thinner wall, is the great cardiac vein. Now, I don't think, as far as I'm aware, there's no reports of occlusion of either of these structures with left atrial appendage closure. So that either means you're all very careful, or it means it isn't actually an issue. Here's an example then to show an ACP going into the left atrial appendage. The idea of this, of course, is the lobe should be distal to the circumflex coronary artery. So the lobar portion is just being delivered here. And then in a minute, we'll deliver there's the lobe. So that should be distal to the circumflex. And then here is the disc. And if I just speed up the video slightly, you'll see once it's detached, there you'll see that actually it sits very nicely within the left atrium. It's away from the mitral valve. It's away from the pulmonary veins at the top. And if we look at the lobar region of this appendage, you can see that the lobar region of the device is distal, in fact, to the circumflex coronary artery, which is marked by the probe. So it's within that region, and we can check that by looking at CT images once we've implanted the device. Here is the same heart, but this time with an amulet device. So the lobar region is being deployed, again, distal to the circumflex coronary artery. And then it's perhaps not the perfect deployment, but this is, a simulation. And then we will have the disc being deployed in just a moment. So here comes getting the right angle, and here is the disc being deployed. So exactly the same, 18 millimeter amulet. Here's the disc there, and again you see that's very well clear of the mitral valve and of the pulmonary veins at the top. So really both look quite nice within the same heart. Finally then, looking at the os or the orifice of the left atrial appendage. So usually the os is oval, but it can vary in its shape from teardrop to circular. It usually lies obliquely with respect to the left pulmonary ridge, the pulmonary veins above, and the annulus of the mitral valve, which you see here. But of course, there can be lots of variations in that in patients with atrial fibrillation. Probably the most important thing to think about is the position of the appendage and the os with respect to the pulmonary veins. And this is quite a nice study that shows that variation on CT images. So the appendage is in blue here. And what you'll recognize is that in most instances, the appendage sits in the middle of the two pulmonary veins, and that allows you to access it nicely with a fairly standard transeptal puncture. But it can be high on the roof of the appendage, 15%, or very low down and close to the mitral valve in about 19% of the cases. Why is that important? Well, certainly high takeoff may be risky for the pulmonary trunk. Here you can see an appendage, perhaps a chicken wing appendage, which is rising at the top of the body of the left atrium. There's a single left pulmonary vein there. And you can see the angle of this appendage really brings it exactly next door to the pulmonary artery. And so there is a risk here of erosion or perforation of the pulmonary artery. In terms of the mitral valve, so if the appendage is lower down, getting a device into this position, I think, has been shown to be slightly more difficult, and clearly you'd want to avoid being close to the vestibule or to the mitral valve leaflets. The final thing I think just to mention are the pockets of tissue which are adjacent to the os of the appendage. So here you can see quite a large atrial appendage. There's actually been a mitral valve replacement here, which we've taken away. And just inferior to the os of the appendage, you can see a second appendage or a second pocket. So these have been described as extra appendicular pectinate muscles. And certainly the structure of these is exactly the same. If you look at them and if you transilluminate them, they're exactly the same as the lobes of the appendage itself, the lobar region of the appendage. So they are thin-walled. There are pectinate muscles there, but most of this region extending into what's being termed the vestibule is thin-walled. So another important thing really to note, I think, on the imaging prior to implantation. So hopefully I've given you an idea, an overview of the proximity of the LAA to surrounding structures. I think it's straightforward to divide the appendage into the three parts that I've described to you, the lobar region, the neck, and the os. We can make things slightly more complicated by talking about the limbus, but happy to discuss that with you. And the success of procedures really doesn't depend just on the skill of you as the operators or the imagers to give you the correct information, but we've also got to have a good way of reliably describing the anatomy of the appendage. Thank you.